Hello, everyone. I'm Sherry Rolfing, your host of the ACAP Preferred Vendor Education Series, and I'd like to welcome you to our latest session presented by Catalyst Solutions. Their team will be presenting a roadmap 2025, cost pressures, regulatory challenges, a new administration, and the way forward. But before I turn it over, I have a few housekeeping items. This webinar, along with all ACAP calls and webinars, will be held in accordance with ACAP antitrust guidelines. These guidelines can be viewed on our website. We will record today's call and we'll post the slide deck and the recording on our website by tomorrow morning. The link to these items can be found in the invitation sent to you for this webinar. Please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors like Catalyst Solutions on our website. Look to the top of our homepage and click on the preferred vendors link. You can also post an inquiry or even an RFI or RFP on the preferred vendor connection portal. During today's session, you can ask a question at any time by clicking on the Q&A icon in your Zoom window and typing your question. Now I'll pass it to Sass to get us started.
Thank you, Sherry. Welcome, everyone. And I see folks are still coming in, but in the interest of time, we'll get started. A lot of what we'll present, obviously, with the new administration and the policy changes, none of us know for sure, but we're going to try to talk about certain themes and what we can all do as plans to future-proof our business. So let me go to the next page. So these are I have a couple of very knowledgeable speakers along with me. I'll let them introduce themselves. But Dr. Vipul Mankad is on our advisory board, and Anish Kumar is our Chief Digital Innovation Officer as well as on our advisory board. Next page. Quick background on me. I'm the president at Catalyst. I've been at Catalyst for about a year, just completed a year. I'm just passionate about healthcare. We all have to work for a living, but I don't feel like working when I'm doing things to improve healthcare. And my career has been in healthcare services and technology. I won't go through the positions I've been at, but most recently I was at Gainwell, and then I've worked at several companies in healthcare roles, including Kaiser Permanente, where I was a business transformation and strategy executive, learned a lot there. Move forward, please. We have, quite a bit of material, so we're going to try to move as quickly as possible. Stop us if you have a burning question, or send us a message. I'll try to monitor those, and if there is a burning question, we'll try to take that on. Otherwise, we hope to have leave time at the end to discuss any of your questions and open it up. So we'll start by, I just want to give a very quick background of Catalyst so you know who we are, and then we'll pass on to Dr. Mankad to go over some of the regulatory changes and other things. So quickly, Catalyst at a glance. We are, as Sherry mentioned, we are a ACAP strategic partner. We have been in business for 25 years. When our founder, Rachel Spilo, who is currently our CEO, started the business, she founded the business 25 years ago, and then we've only served health plans. It may seem small that we only serve health plan, but we've served over 200 health plans, which gave us the privilege to serve over 20 million Medicaid and Medicare Advantage members. We're completely a US-based company. We have partners offshore, but we're a US-based company and present in 46 states. there's a lot of services we provide when we say, stay on the page, please. When we say that, Kevin, can we go back to the prior page, please? When we say that, we only service health plans, there's a lot of services we provide, but when we, kind of boil that down, there are really four outcomes that we deliver, right? What we call the quadruple aim: better member experience, better health outcomes, better provider engagement and experience, and while reducing cost. And we do that, with multiple solutions, right? We have our own core claims platform. We work with almost every other claims provider and other solutions. We have a suite of AI solutions, which we'll talk about. BPO services, based on the outsourced operations we run. We are almost, like a mid to large size plan. Technology services, we've done over, 250 claims system implementations, and then strategic consulting services and very specialized talent. Now next page, please. So when we say reduce costs, better health outcomes, better provider experience and member experience, these are very few select services. You may wonder, how does a company provide better health outcomes, right? So we have tools and services for higher clinical quality and processes, star ratings, member engagement. Dr. Mankat is going to talk about some specific case studies. And around the provider experience, you may remember the triple aim of CMS. We added the provider experience because that's increasingly an extremely important part of a health plan, successful running of a health plan. So enrollment, credentialing, data management, prior auth. There is a lot of things going on with prior auth with upcoming regulations, and then member enrollment. We actually have an omni-channel contact center platform, that comes, it comes by the drink, so to say. So it's offered in a PMPM basis. You don't have to go through an implementation or a large upfront cost. And then around cost reduction, I'll cover more around cost reduction, but significant savings, and we're seeing increasingly with application of AI, we're delivering significant savings to our health plan clients. So I'll my privilege to hand over to Dr. Mankat to give a quick glimpse on the policy initiatives and then really drill down into improved health outcomes.
Thank you, Sas. Can you go to the next page? So let me provide you my background briefly. I am an academic pediatrician with a subspecialty background in hematology oncology, taking care of seriously ill children with blood conditions and cancer. I was fortunate to be entrusted with leadership positions in academic health centers, and I'm not going to list all of those, but let me just mention that I founded a children's hospital in Kentucky and led a large faculty group practice consisting of 500 physicians at the University of Kentucky. So from the provider vantage point, I can tell you that the work that you do as the community health plan leaders is so essential and critical to the work that we did as a provider, or we do as a provider. And I admire what you do, and I extend my thanks to you for what you do. In another relevant role at the University of Kentucky, I founded a physician and hospital-owned health plan, a full-fledged insurance company, which is still there. It's called CHA. So I do have a perspective of a health plan from the executive and board member vantage point. So after all that academia, I obtained a Robert Wood Johnson Foundation grant to work at the US Senate in the policy advisory role in the Committee on Health, Education, Labor, and Pensions. And then a year later, I served as the senior medical advisor at CMS. So during both of these years, the White House, the House of Representatives, and the Senate were all under Republican control, the second Bush administration. So I developed in-depth knowledge of how Republicans generally think, and also the appreciation of what the lobbyists do. So when the lobbyists come and present their views or positions, I listen to them, and I can share with you how a person on the other side can thinks about the proposals. Now, having done that work in the Senate, then I satisfied my entrepreneurial streak by founding an ACO. In fact, I helped form 4 ACOs, but one that I founded and owned. And that ACO, integrated ACO, was among the top 2% of the nation in terms of shared savings per capita. Now, I've authored a book which will be published in 2025, entitled, "Who Am I and Who Might You Be?" And when I started thinking about this webinar, I said, well, I forgot one big question, and that is, who are we as a nation? So if you go to the next page, Kevin, this is a rhetorical question. And if you see the 2 paths before us, they look strikingly different. On one side, do we want to be a nation where all citizens have opportunities to lead a healthy and happy life? Or do we want to be a country where some citizens have good health care, but they are surrounded by people who don't have good health care and have the misery from needless diseases and disabilities and die prematurely? Now, obviously, most people, in fact, even politicians, will say, we're on the side of serving everybody in the country. No question about it. In the US, we don't see people dying on the street, bleeding to death. That doesn't happen. But how we go about doing it, that is where the spectrum of variation is. So if you go to the next slide, now that we have the Republican administration that's about to take office in January, the question is, what would be the policy initiatives that might be proposed? Unfortunately, we don't have a lot of direct information. Candidate Trump was somewhat vague in describing healthcare proposals. The election was fought on immigration and inflation. So when candidate Trump was asked in a debate if he had a healthcare plan, he said, I have concepts of a healthcare plan, but then he didn't really present the concepts. So we really don't know what sort of policy initiatives will take place based on President Trump's thought processes. But we know what Republicans generally think, because that's the group that he's going to have to work with, and they have the majority. So, for example, we know that Republicans often favor the policy decisions at the state level, and they want to shrink the federal government. So if the national health policy shifts to the states, depending on the budget in each of the states, there is likely to be a shrinkage in the Medicaid membership. There is also likely to be a thrust on privatization, presenting choices, and competition, at least on paper. That will be the goal. And that could present challenges to the Affordable Care Act or plans that are compliant with ACA. We also hear that there is a possibility of the repeal of Medicare shared savings program, even though in the past administration, they showed that the MSSP actually generates cost savings and constraints cost for Medicare. So if that happened, then higher premiums are likely for traditional Medicare. Now, of course, the commercial plans can still offer the shared savings option, but the Medicare, the traditional Medicare costs and premiums could rise. Now, there is a campaign slogan of Make America Healthy Again, MAHA. And in the, it's somewhat vague, but if MAHA or Make America Healthy Again reduces vaccination, then vaccine preventable diseases would increase and the medical costs will go up. For competition and privatization and to address some of the issues with pricing, often the transparency is promoted, and Republicans are in favor of transparent competition. And if that increases, then you may see increased IT requirements because there will be more reporting of prices and options. The site-neutral payment reform would probably lower the medical costs for surgical procedures if whether they are provided in the hospital or in the ambulatory care center. Both places would see a decrease in the costs. And then finally, if the drug negotiation ability of the CMS is curtailed, then the drug prices could increase. So these are some of the trends that we could look at. And we would not be sure until the health secretary is confirmed and policy proposals are on the table. Kevin, can you go to the next page? Now, one thing that is not going to change, and that is the principle that the health impacts on the productivity of businesses and the nation. So healthy employees are more productive. And there are reports, both from academic institutions, but more importantly, from business consultants, that if you improve healthcare and if you improve population health, then you can add trillions of dollars to the economy. Businesses become more efficient. The employees participate more often. They are sick less, and they're more productive. So I won't go through the busy graphics on the right side, but that essentially generates better health generates greater business output. Now, why do I mention this? Because what we find is that in the Republican offices versus Democrat offices, there is a different way of reacting to the policy proposals. The Republicans typically want to know the impact of any policy proposal on business and GDP, as opposed to the social good side, which often is the issue that the Democrats champion. If you go to the next page. So the other focus is going to remain the cost reduction or cost containment. And I'm going to present a case study to you on how that can be done. So I mentioned that I founded an ACO in Texas. It was called Integrated ACO, and it was in the top 2% of the US until it was acquired in 2019. Now, how did we do that? Well, we used the descriptive analytics, where it's very simple analytics, like a list of expensive patients that you provide to the doctor. Health plan provides to the doctor. Similarly, Every day you provide a list of admissions from that practice during the previous night. You might say, well, shouldn't the doctor know? Well, usually they don't, because patient may be admitted from ER from the urgent treatment center, from the specialist, and so the physician shows up in the morning. They don't really know that their patients are in the hospital. And a typical physician would simply jump into they see the waiting room full of patients, and they just go into the examination rooms and start seeing patients without really thinking on how they should plan the day, and how should they plan their week, and where should they put the focus. So if you provide this list, they can take common sense solutions. I've heard physicians say, oh, really? Margaret is costing $1 million a year in healthcare costs? I didn't know that. I mean, let me work on better management of her asthma so that she's not hospitalized. Let me manage her diabetes better. So the common sense solutions often come from very simple descriptive analytics. But the key here is to provide that in a timely manner. But we also did some fancy stuff. I'm an academic and I just like doing some innovative things. So before AI, we developed the predictive analytics. And we predicted many different events that could be prevented. But let me just discuss the congestive heart failure admissions. And what we did there is to predict which of the congestive heart failure patients in a doctor's panel would be admitted in the next 6 months. And the accuracy of that prediction was 90%, 90% true positive, 10% false positive. And that also happened in the first 10% of the predictions. So the point I'm making here is that, eventually, if you predict 100% of the population events and you wait, then everything is going to happen. If you're 90% correct, then over the course of 6 months, you will be right 90% of the time. But the key here is to do it rapidly in a timely manner before it happens. So the first 10% of predictions were able to give us a list of patients who might be admitted in the next 6 months. And then the physicians provide the outpatient care to those patients, make sure that they are on the beta blockers, and if necessary, send a home health nurse to check and make sure patient doesn't have a side effect, the dose is correct, and so on. And that reduced the cost in our ACO. The insurance companies were very happy because we had both the Medicare and the commercial companies. The insurance companies were happy because the costs were reduced. The patient was also happy because they didn't have to go in the hospital, regardless of the excellent hospital food. They don't want to stay in the hospital. And finally, the physicians were also happy because they were rewarded with the shared savings bonus. Now, this is where the ACO work ended. But if you were a community leader, you would then say, well, okay, if some of those people were employees that did their participation increase in the businesses, was the business productivity, did it increase? And then what was the multiplier effect? So, you take the production from one person to the company, to the county, to the state, to the nation. And, there are methods of doing this multiplier calculations. We didn't do that in that situation, but I've done that in other situations where you show that when you do something good, there is a multiplier effect on the businesses and GDP. So if you go to the next slide. So what I just reviewed is the idea that we need to provide timely information. And I'm not going to discuss the details of the next two busy slides, but the point that I want to make is that Catalyst has several dashboards in many different situations that we can share with you. And And, so that the department manager or COO or CEO is able to see how their department or the company is working on a day-to-day basis and take actions. The same kind of dashboards can be prepared for a physician office. So, the doctor would then know what's happening in his practice, which patients that he should focus on. And I think that providing this timely information will make the system more efficient. So Kevin, skip this slide and the next slide, and then I will conclude with the last summary of it, so that we now know that the policy changes are somewhat of a wild card. It's nearly impossible for any of us to predict changes that might happen. But we do have some ideas about what might happen. And regardless of what happens, there are some principles that are not going to change. So let's work on those. Work on cost reduction by keeping members healthy. And you do that with providing timely information, dashboards, monitoring medication adherence, clinical and utilization monitoring, whole person care, food as medicine, all kinds of things that you do to keep the person healthy so they consume less healthcare costs. And use the analytical tools, both descriptive, predictive, and prescriptive, and AI to assist the providers in taking common sense steps. And I think when you do that, give the right care, the right time, the right location at an affordable price, then this will improve the population health of the community. It will increase the economic output. And if you then have a calculation of the multiplier effect on the community, the county, the state, and the nation, then you can take that to the policymakers and leverage the case of the community health to either defend yourself from the assault of new policies or to propose policies that favor the community health plan. So good luck to you. And, we will be watching what happens in our country, but, there are certainly some key things that we can do even now. Thank you so much. Sas, back to you.
Anish, are you?
Absolutely.
Yeah.
Good afternoon or good morning, everyone. I'm delighted to be in this conversation and want to take the next 10 to 12 minutes speaking about two things I'm passionate about: member engagement and provider engagement. Feel free to have any questions. A little bit about me. I've spent about a decade at large health plans. You can see that mostly on the digital and product management side. I also worked at Gainwell with SaaS, and that's how we are here together. My eclectic career has included care delivery. I owned a multi-specialty rehab clinic in San Marcos, Texas. A little bit smaller than what Dr. Mankar did, but still it was a lot of fun. And have founded and grown two startups, first being the COPD clinic, Azul Care, and second, a consumer price transparency startup that eventually pivoted to provider bad debt reduction. So really the individual side and the provider side in one company. I already spoke about Gainwell, and I started my career in Silicon Valley in the tech industry. If we can go to the next slide. We've spoken about a number of trends today. Some things that I want to emphasize: on the left of the screen, you see some member related or member relevant changes, and on the right side, perhaps more provider approximate trends. So there's a lot of noise around retail clinics, and also a lot of Schadenfreude that Walmart Health and Village MD have crashed and burned. At the same time, the investment in this space continues at eye-watering levels. So Risant from Kaiser and Geisinger, General Atlantic just bought Summit, Summer Health, excuse me, and Amazon and so forth. And I do believe this will be a competitive driver in the year and years to come. A number of changes happening in terms of AI, and I believe SAS will speak a little bit to that. And I believe that this will help the member and the provider experience. And lastly, somewhat sobering, our industry continues to rank fairly low uh, with the true customers of the industry, who are individuals or patients, and the employers and state agencies that pay the bill, most of it, in terms of value, transparency, and convenience. At the same time, I'm hopeful that the coming year will make the industry better on that dimension. On the provider side, most of you are probably aware of the recent tightening of high-star ratings, if you will. 5-star plans, there were 32 last year, or the year before last, I should say, and for last year, the number went down to 6. And other high-risk coding type of metrics are also being tightened at the same time that most clinicians and administrative staff report burnout and frustration with the profession. So we have a big challenge with members as well as the providers. If we go to the next slide, as I look at a lot of these things and adding to Dr. Mankart's excellent description of what the government might do, I have a hopeful perspective that a model, the so-called fee-for-service, arm's length interaction model between the payer and the provider is bursting at the seams. It is not doing the job, so to speak. And we can look at the 3 things that are happening that you may find useful in your business. Is that group PPO plans are becoming less competitive. First, with the tech-fueled payer providers, sometimes called payvider type companies. Now, today they are still on the fringes, and there's a lot to ridicule about them. But every year they become better, whereas the PPO plans stay where they are. The second part could be of a lot of interest to plans in ACAP is narrower network ICRAs that have local or somewhat thin networks with a wrap around national network. And these plans allow an individual to purchase health benefits with tax advantaged money from their employer with no lower or upper limit. It's a pretty powerful instrument. And then perhaps more soberingly, catastrophic coverage, so-called junk plans, may come back. It remains to be seen how the administration actually works, but that is going to create medical jeopardy for the people who can least afford it. And it clearly provides some challenges for ACAP plans. A more subtle trend is that the cumulative deductible instrument is becoming weaker, if not downright damaging to progress. And we see the beginning of per episode deductibles, much like in auto, home, and life, and or high copay and no deductibles at all. Aetna Simple Pay, which is a joint venture with a company called Simple Health, I believe, started and is getting a very good ink. So I encourage you to look at what that may mean. On the government side, and Dr. Mankite has done a great job. I want to present the 2 things that I have been reading a lot about, which is clearly budgetary and rhetorical pressure on Medicaid and CHIP. Less so on Medicare because of obvious voting dynamics, but unfortunately, the voting dynamics do not protect Medicaid and CHIP that much. This is given that even though 80 to 90 million Americans are on Medicaid and 45% of births in America are to Medicaid beneficiaries, even with those numbers, we expect budget pressure. And lastly, we already spoke about increased difficulties for high star ratings. So as we look at all this, what could you do? A couple of recommendations for the members in this session. Again, this is the time to look at fundamentals, not get distracted, intimidated, or carried away with what's happening in DC, as much as there are long-standing issues that we as an industry have done a less than stellar job with. And member engagement and provider engagement has enough of those. So we need to focus, for example, on the digital front door capability that has been a talk of town in the industry, even when I was at Aetna in 2010, around 14 years ago. SAS spoke earlier about omni-channel contact center. One of the reasons that we are all very excited about that capability at Catalyst is how important it will be, not just to member satisfaction, but also to their care journeys and eventually care cost, as Dr. Mankad mentioned. And I highly encourage you to look at that as a worthwhile, compelling investment. Longer term, obviously, there are things such as a greater footprint in individual space, a radical redesign of products, etc. On the provider side, prior authorization, clinical claims review, and other bureaucratic instruments remain the bane of practice. And there are CMS rulings, specifically 0057F, that are going to automate this for government-mediated plans. And my recommendation is to actually bring it to your entire book. There is no downside and a lot of upside. And the return on investment is pretty much guaranteed because of the compliance requirements. Broader networks, more challenging from a medical economics perspective, also from a care journey guidance perspective. So looking at narrower networks, and then starting to do episodic or service line capitation or outcomes-based contracts. The term value-based care has been around for 10 years. Finally, it may happen. And longer term, depending on your risk appetite and horizon, some type of an investment in care delivery will become natural as payer and provider value streams start to intermingle. So those are some of the things that you can practically start doing in 6 weeks. In fact, you probably don't even have to wait 6 weeks. You can start them in 2024. But January 1st would be a great day to start looking at some of them. Next slide, please. Lastly, I want to mention some of the experience we had. We've spoken about value-based care. The one thing I would, a couple of things I would say. First, it is a key pillar of the transformation of the industry. So with all the jokes aside, it will happen. Outcomes-based payment will happen in the industry. And the way to cross the Rubicon is to really take a phased approach. We worked with a Midwestern Blues plan, and this is a little bit of content that we used there. And the eventual result was that something that looked impossible, at least for some lines of business, was actually a very doable project that can potentially be replicated across their entire book. So I encourage you to think of value-based care not as a theoretical thing, although it did start at Dartmouth Hitchcock, but as something that is here now and is a key arsenal, a key piece of armament in your competitive arsenal. And with that, I believe my session is at the end, at about 1 minute left. I'll be happy to answer any session-specific questions or comments if there are any. I don't know, Sas, if you're seeing any. Otherwise, I'm, of course, available for the rest of the session.
I haven't seen any questions come in yet.
Okay, thank you.
Looking.
I also have a timer going, and I see that I have 54 seconds left. So good. So I'll turn the mic back to Sas.
Thank you, Anish. So I guess I have the hardest job here, cost reduction, everything you heard so far and what may probably is coming down the policy pipeline. You can go to the next slide, Kevin. What I'm preaching to the choir here. You all know this. Higher utilization, lower reimbursements, high cost of compliance, deadlines, and then added to that now is our policy uncertainties, right? So how do you reduce cost in that environment? But irrespective of the administration, and I think our industry will have to figure out a way to deliver better healthcare in a more cost-effective way, right? So, and I've been CFO several times in my career, and what we used to always say is, what is beyond our control, we can't control that, right? So there's no point complaining about that. What can we control and do, which would, irrespective of whatever happens with policies or market, will help our companies. And what has worked for me personally, when I've run large operations, and what we do as Catalyst is, really get down to measuring. And measurement, baselining is a really, really good first step to any improvements, right? Whether it's cost reduction or improved performance. So, we have a methodology, and it starts with really baselining, any health plan operation, right? And I'm sure none of these would come as a surprise to you, but what is your PMPM or per claim processing cost? Is that different by line of business? What's the cost per member call, right? Instead of call, if it is a text or if it is a chat, what is that, right? Is it less expensive? Provider. And there's a whole, these are tips of the iceberg, right? So there's a lot of other metrics below this. Operational G&A cost as a percentage of revenue. With the MLR, targets and all that, we already have a cap on that, but then, are we able to predict these costs and then continuously and reliably keep reducing them? And then the other piece is, the uncertainties around utilization or enrollment or membership. Are we nimble and agile enough to rapidly reduce some of the costs, if revenues or premiums are lower, or utilization is higher and other costs that are not in our control goes up? Star rating, we talked about the star rating with at least one of our clients. We were able to see a $16 to $17 million bottom line impact from moving up 1 point in the star rating scale. And while it may seem daunting, but there are a lot of kind of administrative and I would say detailed monitoring of metrics where you can prioritize certain things to really get a higher star rating, or at least prevent star rating from coming down, as Anish and Dr. Mankat was both saying about the challenges around star rating. Also, really identifying areas and functions in an organization with the most variation from standard cost benchmarks. So, that's usually, I had a prior boss who used to say that variation is the enemy. So really looking at that, and none of this is really, targeting negatively, right? These are all things that, as we drive a car, we set our mirrors, right? And so that we don't crash, we know where we are going, we have a good idea of our surroundings. So a lot of these things are sort of dial tone, basic thresholds as we run the business. And then how satisfied are we with the visibility of the leading operational metrics, right, that are impacting financial performance to be able to manage proactively? Because often what happens is by the time we find it and we go cure it, 3 months have gone by, right? And it's not, you cannot get back that cost overrun or whatever it was, and it would impact the entire year. So again, very small sampling. We obviously have a methodology and a way to actually go very quickly, get some of these metrics to establish a dashboard, a scorecard for health plans. Kevin, let's move to the next slide. Again, cost reduction, execution playbook. I've used this, repeatedly and not just in healthcare, right? In other industries as well. I remember when I, came I did not grow up in the healthcare industry. I worked in other industries like high tech and others, financial services. And then when I first came into healthcare, I was asked to look at, nothing that's bleeding edge, things that are standard, proven, and many things that other industries had done 20 years ago were considered bleeding edge in healthcare. So there's a lot of basic blocking and tackling, that we can do. And the methodology here is a common sense based methodology. Can we eliminate, revenue leakage, underutilization? Where are there fixed cost structures that are not linked to revenue or premiums? Overheads, are we, are there a lot of outside services, that are being done at a higher cost than they should be? Capital investments, with low or no ROI potential. I mean, this is where we are helping a lot of our clients, to avoid having to do a large upfront investment before getting any returns. Standardizing spans of control, process, policies, procedures. We actually have an AI tool I'll talk about quickly here, that goes and gathers a lot of that information, right? Where the standard operating procedure and how processors are working are not in alignment, right? And that creates a lot of issues. Support services and functions to meet industry benchmarks. I've worked in organizations where the budget was a percentage of revenue rather than a bottom-up cost. And looking at procurement, there's usually some low-hanging fruit in terms of looking at large top spend categories and going after those. Consolidation, support organizations, shared services, technology rationalization, vendor consolidation, office footprint. I don't know if that's one, but Catalyst, for example, I mean, we encourage virtual work. There is a lot of monitoring tools. It gives our employees a good work-life balance, but it also allows them to be more productive because they're not, on an average, someone actually commutes 13 days of a year to go to work. Automation, again, no surprise here. I mentioned avoiding upfront costs, so OpEx-driven automation solutions, and then using the cloud. I'll talk about AI. I mean, and it doesn't have to be like Gen AI, right? There are a lot of basic automation leveraging AI that we can leverage. And then, using third parties. I mean, in many cases, our customers use us as an insurance policy in some ways, right? Where we are contractually guaranteeing savings to them year over year, right? So their cost is pretty predictable, and it challenges us to do better every year. Looking at suppliers for co-invention, right? Where a supplier may have some innovative product or solution that you can partner with them, whether it's a joint venture or something more arm's length, but get the functionality, get the improvements, right, without having to do that internally, because that's not may not be a core competency. Kevin, go to the next slide. So again, busy slide, won't go through everything. But one of the things that we have been, our founder, Rachel, and I, we jumped in, early on into AI. We believe it is going to be, like the internet was, right? It would be the next big thing. And there would be a lot of hype, that would go and die down, but some of the basic benefits of AI are going to be very, very helpful. And so our approach to AI is we're not the open AIs or the Microsofts or Googles of the world. We don't come from, computing power or developing any of that. Our approach to AI is bringing our 25 years of deep industry knowledge in health plans, as well as the data to train the AI agents. Just as we train our employees, to be very high performers. And to that, one of the tools that we have, AI tools that we've been leveraging, significantly is a process discovery agent. Where it's a non-invasive tool that sits on desktops of employees, and it monitors the work, and then you can input other things, like you can input a desktop procedure and then monitor actually what's happening in the desktop and compare those, and be able to give additional training to the employee, because or correct the standard operating procedure. And none of these, by the way, we offer to our clients before we have used it ourselves, right? So we run a fairly large operation, and we use all of these. They're tried and tested within our operation, and that's how we offer it to our clients. And when we leverage it for our clients' project, we contractually guarantee the savings, right? Because they don't have to trust that it will work or go through the whole 6-month due diligence. They're contractually guaranteed on these savings. So what it provides are outputs, and I've sat down with CEOs of plans and gone through those outputs, and it's eye-opening in many cases, right? Because this is not a time and motion study or a process mapping that a consultant goes and sits beside your employee, and the employee is scared and they're anxious. This is something that's happening very non-invasively, but gives really good insights, right, in terms of processing time and things like that, and allows us to determine if that process can be actually automated, right? And by the way, one of our basic principles is human in the loop, right? So we never do anything where a human being is not in the loop. So AI isn't going off and doing things, beyond our control. So what we've seen, are almost 25 to 50% increase in accuracy, less rework, more first throughput, and then increase in productivity. In many cases, there is a 50-page policy document that and we process extremely complex claims, high value, high dollar, where you have to be very careful, right? The experience level of our agent, and the amount of careful monitoring of the policy and all that they do, which is all great. But think of the AI agent as almost like a very smart intern, right? Who's running off, getting the relevant policies, putting them up, or providing some guidance on the screen to say, every other time you had this claim line item, this is how you coded it. So, there's a validation. We're doing a lot more, able to do a lot more audits, to improve the accuracy. So, happy to show any of these if you're interested. And then there is a host of other agents that we have developed, that are ready to be deployed. Again, claim adjudication, payment compliance, IT help desk, HR help desk. We actually have our own HR help desk agent, where if you have a HR policy question, you go to that agent, and you can do that in plain English on Teams or by email, and it would answer the question. And if it cannot, then it would refer you to to a HR. It would basically escalate it to someone in HR. But that's reduced and improved employee satisfaction as well. And we have some finance operation agents as well. So I think I'll leave about 5 minutes for any questions. Let me see if I see any questions. Not yet, but hopefully that gave you some. Obviously, Vipul and Anish talked about more strategic. I wanted to keep it quite tactical in terms of what we may be able to do in the next month, what we may be able to do in the next quarter, so that 2025 results can be positively impacted. And we're doing it ourselves. We're doing it with our clients. So hopefully that was helpful in terms of some tangible case studies and linkage to what may happen, which we will not know till it happens.
We'll be happy to answer questions,
Yep.
even if they come later with emails.
Yeah, and feel free to reach out to us if you have additional questions later. I think I see Sherry, how do we? I think I saw a hand.
Oh, the AI question, Sas?
Let me see. What is the
there's a
best place to
question.
start integrating AI into a health plan? Great question. And one that we went through for months to determine where it is. I would say the assessment, the process discovery, because it's not something you're committing to for the long run. What you're doing is you're really accelerating your ability to understand what's happening within your operation and getting a really, really detailed view of that. If you're interested, we can show you some of the outputs. I mean, it gets down to, how are one claim type versus another claim type, how long does it take to process? What's the error rate? How well is your best performer versus, lowest performer? It can generate extremely detailed and intuitive operational guides, right? Desktop procedures, standard operating procedures. So my bias opinion is you start there, because you're not having an agent go do stuff that you may not be confident to use yet, but this is almost a no-brainer. That's why we used it within our operation, that it couldn't harm us in any way. And the information we get is going to be really, really insightful for us to take actions. Hopefully that helped. Feel free to reach out. Happy to talk through how to get started. And it's pretty quick and non-invasive. Other questions?
I don't see any other questions, Sas. As you said, they can reach out to you directly. The email address is on the slide, and the slides will be posted. I wanted to remind everybody that this has been recorded, and the recording and the slides will be posted on the ACAP website by tomorrow. I want to thank the Catalyst Solutions team for a fascinating, and I liked, Sas, how you said it, that it was both strategic and tactical in your presentation. So it gives you some things to think about, but then also things you can do right away. So I want to thank you all, and I want to thank all of our attendees.
Thank you.
Thank you,
Thank
everyone.
you. Have a great day.